weakened or whatever. So that is a concern. So
But
otherwise,
why
these
has it weakened?
the CRI and Pasteur Institute Kannur and the BCG lab were basically closed down in 2000.
Yeah. Oh, yeah, that I remember. Yeah, sure. So BCG, I'm not talking because I think that is another very important subject. I think
basically we're not going to mix. But I'm just saying that we have the capacity to produce this.
Yeah, definitely. Yeah. But I think that is also very important for this topic also, BCG vaccine, particularly for antimicrobial resistance because of the so much of burden of TB in our country.
Definitely.
But there is so much nuances to this adult vaccination that I thought I will just concentrate on a small part of it.
No, surely. I think this will start a conversation around this.
Yeah, it's great. So I'm sure you people are having conversation for lots of many years for now, but it has not come out in a very big way, Adult vaccine. COVID has actually proved that we could do it.
Yes, definitely.
Yeah.
Hello, everyone. Sorry, this is Simran from the One Health Trust. So she's just joining in. But good to have you all here. And well, if there's anything technical, you can just let me or Jane know, and then we can sort it out before we actually begin the webinar.
Simran, the webinar link, the thing is, I think the way it is that you have to register for it. So I'm a little concerned that people may have trouble with that. Do you know how many people are waiting to join?
Yeah, I can see there's 17 people here, 16 people actually right now. So I'll just have a look once more.
This is the people from the technical working group who are part of the webinar. So just wondering.
I see. Okay, for the audience, I'll just have a look and then I'll get back.
Yeah. Dr. Aneja, thank you so much for joining us. I think we're all looking forward to the session.
Yeah, but I was telling Dr. Anurag that he would have been a better person. He's an adult physician, but anyway. It's interesting.
Yeah, hi, Dr. Bhargav. I can see you're online, and I think Sumit is also there. So, hi, everyone.
Sorry, I was muted. Hello, Priscilla.
Hi.
Good evening, ma'am.
Hi, Sumit. You got the thing, na link? I think Jane has sent it out. There's some, I think, issues with registering and then coming on or some such thing, I think. So. But it's okay. We'll just wait for 2 minutes. Is that all right?
Yeah,
just
sure.
give people time to register, and then it takes a while to register, and then click on it and then come. So.
Dr. Priscilla, we already have 23 people, including the presenters, so I guess it's a good time to begin.
Sure, I think, yeah, we can go ahead and start. So hi, everyone, and welcome to today's session. And as you know, we've been doing this webinar series with regard to how vaccination can impact AMR. So this is part of the Global Antibiotic Resistance Partnership. We have a very active technical working group who've been involved in the webinar that we have conducted in the past as well as now, and they've been actively contributing towards the discussions. So we hope to have at the end a policy brief which will help us make some recommendations as to how vaccination can be rolled out and have its own role with regard to impact on AMR. So with that, I welcome all of you, and I will now hand over to Dr. Sumit Rai. Dr. Sumit Rai is a professor of microbiology at AIIMS Mangalgiri, and he has been really involved very actively in stewardship. He conducts a number of workshops and seminars. He's also conducting this year's ASPICon, or I think Antimicrobial Stewardship Conference at Mangalgiri. So those of you who are interested in stewardship as well as love Andhra and Mangalgiri saris, you're welcome to join him there in the first week of September. So with this, I welcome all of you once again. If Erta is online, I just ask Erta to say a few words, and then I'll hand over to Dr. Sumit to introduce Dr. Aneja.
Erta is not in the panel list. I don't think Erta will be able to speak on.
Okay, I just saw her, but I think she may have left and then rejoined again.
She's in audience.
Okay, sure. Then I will now hand over. It's my pleasure to hand over to Dr. Sumit Rai to actually introduce Dr. Satinder Aneja. I had the privilege of meeting Dr. Aneja quite serendipitously. We were part of a meningitis guideline group by WHO. And since then, we've been keeping in touch, and Dr. Aneja has been really gracious to actually be able to join this group despite her busy schedule. Over to Dr. Sumit Rai to introduce Dr. Satinder Aneja.
Thank you, ma'am, for the kind introduction. I have worked in Delhi for a long time, and ma'am's Dr. Aneja's name is not unfamiliar to all of us. And I was there in Delhi for from 2009 to 2021, and as faculty. So we definitely have, even in the microbiology circles, we have heard a lot about her, doing a lot of good work on immunization. So I have the pleasure and the honor to introduce Dr. Satinder Aneja. Ma'am is the former director professor and head of the Department of Pediatrics at Lady Hardinge Medical College. Ma'am has been a distinguished pediatrician with over 4 decades of experience in pediatric neurology, infectious disease, and child nutrition. She has held esteemed positions, including director professor at Lady Hardinge Medical College and head at the Sharda University of Medical Sciences and Research. She has been a key coordinator to national and global health initiatives, serving as chairperson for the National AEFI Committee as a member of the NTAGI and an expert on WHO's Global Vaccine Safety Initiative. Her research, funded by the organizations such as WHO, ICMR, and National Institute of Health, has significantly advanced pediatric healthcare, particularly in the vaccine safety, child nutrition, and neurodevelopmental disorders. With over 150 publications in peer-reviewed journals and contributions in many medical textbooks, Dr. Aneja, she continues to influence pediatric medicine through her research, teaching, advisory roles in public health policy, and a lot of inspiration to young pediatricians and budding pediatricians and infectious disease specialists. Again, my privilege and honor to introduce ma'am. Ma'am, the stage is yours.
So thank you, Dr. Sumit. That was a very kind introduction. So, and thank you, Priscilla, for giving me this opportunity. And as I was telling Dr. Anurag, I'm a pediatrician, but I'm talking about a special population in adults, which which is not my real domain. So my disclaimer is that I'm an independent expert. I'm a pediatrician and I'm not representing any professional bodies or any committees, and the views are totally personal. Also, the disclaimer, I don't have any conflict of interest with any industry or anything. So the topic given now to me was public rollout of vaccination in special population, elderly, immunocompromised, and its likely impact on antimicrobial resistance. So what I would be talking about today is, let us discuss the burden of the problem, like proportion of population which is vulnerable. What are the currently available vaccines recommended for this group? What is the efficacy or effectiveness of these vaccines? And what is their likely impact on antimicrobial resistance? And what are the challenges of vaccination and some programmatic considerations for public rollout? So to start with, let me say that we have a huge chunk of vulnerable population in India. As you know, the elderly population itself is about 10.5%, and it is actually increasing every decade. So this population of which is adult is taken as 65 in some places, somewhere 55. And this is according to the census that people over the age of 60 years, roughly about 10.5% of population, which translates to 14.9 crores. And 11% of the adult population, which is about 77 million or 7.7 crores, would be diabetics. Then, of course, we have a huge chunk of people with hypertension, cardiovascular diseases, chronic respiratory diseases, kidney diseases. We have another big, I mean, not a very big, but a significant proportion of a population in tribal areas and central India has sickle cell disease, hemoglobinopathies. And we also have people on immunosuppressive therapies, especially organ transplant, bone marrow transplant, malignancies, and of course, HIV and immune deficiency disorders. This is not the complete list, but this is, I would say, the top 4 or 5 make the real chunk of a vulnerable population. And not to forget the pregnant women and the neonates less than 6 weeks who are not eligible for vaccination are also at risk. However, this is a separate topic and we are not going to discuss it today. So, but this again this is also a special population in our country. So if you look at the chronic disease in India, because that is one which makes them more vulnerable to risk for infectious diseases, we are just same percentage of population proportion as the global burdens. So globally, if you look at it, all excepting for the cancer and HIV, we are actually the diabetes and is higher in India as compared to the global burden. Chronic kidney disease is almost similar, respiratory disease is almost similar. So it's a huge chunk. And if you look at it, the prevalence of people per 100,000 people, and if you translate into numbers, I'm sure this is going to be a population is going to be a large chunk of population has all these disorders. And why this population is important? Because they have a risk of vaccine preventable disease in this population. Risk for all-cause pneumonia is about 3.6 times higher. Invasive pneumococcal disease is about 4.6-fold higher in immunocompromised as compared to general population. They also have high risk of developing serious influenza-related complication, high risk of secondary bacterial fungal infections. And we know that influenza is also related to common causes of severe disability in adults. For example, cardiovascular events like stroke, congestive heart failure, and pneumonia. Another thing is that mortality in patients with pre-existing chronic diseases is observed to be much higher when they have this respiratory disorder. Especially, this was very well observed in COVID-19 pandemic, as also in 2009 H1N1 pandemic. So this is a well-known facts, and we are cognizant of all these facts. Besides this was a general predisposition. There are conditions like specific conditions might be predisposed to specific infections also. For example, in diabetic patients, chances of influenza, sepsis, skin infections, UTI, fungal infection is much higher. Chronic kidney diseases are more predisposed to influenza, hepatitis B. And for COPD, for example, influenza and pneumococcal pneumonia would be the biggest problem, more predisposition to the respiratory infections. Chronic liver disease and hemoglobinopathy, specifically for hepatitis B specifically, HIV, we know all bacterial infections, tuberculosis, herpes zoster. Then we have a population of sickle cell disease where you have invasive disease due to the capsulated organism, for example, Hib, strep pneumonia, meningococci. And the elderly, they are actually prone to all these respiratory infections, and they have waning immunity to most of the infections, and they are predisposed to specifically to pneumonia and zoster. And if you look at this 5 communicable diseases and associated deaths, the respiratory disease, acute respiratory infection, and pneumonia. The red bar talks about them is depicting the mortality, whereas the blue bar is for the total cases. And you can see the both total cases and deaths are primarily due to the 2 things, acute respiratory infections and pneumonia, if you look at the communicable diseases. So this is a really big, the respiratory infections are a big problem for this population also. And this is a pie chart, pie diagram of the vaccine avertible AMR burden of infectious syndrome by pathogen. And here again, if you have a look, the LI, lower respiratory infections and thorax infections are caused the 30% of that. And another chunk is by tuberculosis and bloodstream infections. So I thought I would mainly restrict my talk to the respiratory and LRI and in pneumonia in this talk, because this is the one which is caused the maximum burden. So what vaccines do we have for respiratory infections? And these are available globally, as well as many of them are available in our country. So pneumococcal vaccines, we had the polysaccharide vaccine for a very long time. And from 2000 onwards, globally, there was pneumococcal conjugate vaccine. First came 7-valent, then 13-valent, and India is producing itself the 10-valent, 14-valent, and nowadays you are moving on to 15-valent and 20-valent vaccines in the high-income countries. We also have influenza vaccines, which can be trivalent, quadrivalent. There are different products for influenza vaccines. And we also have a live attenuated vaccine for influenza. We also had COVID vaccine, which I'm not discussing, but this was a very important vaccine, which also was for the respiratory infection. RSV vaccine is available globally, but although not yet in our country. Then we already have this Hib vaccine in our national program as a part of pentavalent, but it is also available for the special population as a separate vaccine. Not to forget the pertussis, DPT, pertussis and diphtheria and measles itself also prevent respiratory diseases in children. But for our population, I think the 2 vaccines which are most important would be pneumococcal vaccines and influenza vaccine. And and they're currently available in our country. So I will limit my talk to these existing vaccines and which are the most important for our population. And just to put it back again in perspective, that the risk group for pneumonia is very high if you have if the age is in elderly and if you have risk factors. So the green bar is for the more than 65 years, and you can see that if there are any risk factor, the risk of pneumonia is growing higher. For example, in diabetes, the risk is almost 3 times higher, heart disease or 3.8 times higher, and if it is smoking, alcoholism, rheumatoid arthritis, liver disease, all these comorbidities increase the risk. And most of the adult physicians would agree in the geriatric population, it is quite common to see not one, maybe 1 or 2 or more even comorbidities may be having. So this group is definitely much more vulnerable to this pneumonia as compared to the other group. And We have had several consensus recommendations for risk conditions. We have an Indian consensus guideline on adult immunization, which was the latest one, I think. We also have guidelines from the professional bodies for community medicine, professional bodies for physicians. So they are all recommended all various vaccinations. But for respiratory diseases, it's definitely they recommend inactivated influenza, and also their the conjugate vaccine, and also PPSP23. You can see that they are all these recommendations are already there. So it's not that there's no recommendation. There are recommendations, and these are vetted by many professional bodies, and all professional bodies, IMA, physicians, professional bodies, and community medicine, all have made some recommendations for this vaccinations. Yeah. So let me take over you to two vaccines, and I will talk a little in detail about this pneumococcal vaccine and influenza vaccine. So again, to say that the burden is higher in our lower and low middle income countries, and it is also higher in age group more than 70. So this point I have again making, because this is something which we need for advocacy of these vaccines. So from 50 to 69, as well as from more than 70 age group, if you see the middle one, low middle income countries, the high income countries are giving the vaccine, but the main brunt is faced by the low income as well as low middle income, because the deaths due to pneumococcal lower respiratory infection as well as lower respiratory deaths per 100,000 are higher in this population. So this is a significant problem. What is the scenario in India? So we know that strep pneumonia is the commonest organism causing community-acquired pneumonia. Almost 1/3 of all cases which are diagnosed to be having bacterial pneumonia are 33% are due to strep pneumonia, and accounts for about 43% of community-associated pneumonia, especially with COPD. And it is also frequent cause of secondary bacterial infection following any viral lower respiratory tract infection, example, influenza also. So the other important thing is, besides the community-acquired pneumonia, it is also causes invasive pneumococcal disease, which is a very serious condition, which could be either in a form of sepsis or pneumonia with bacteremia or as meningitis. And this, again, the incidence is high in the extreme ages, and say in the more than 65 years, if it is near 9.8 per 100,000 person years, but in adults with diabetes, it becomes almost 3 times higher. So the rates are higher in adults with diabetes. And the case fatality is also high. It is about 17.8% in overall of invasive pneumococcal disease, and it is the highest in adults over the age of 65 years, which means it's almost double that overall case fatality rate. So again, this is a serious condition, and there is no doubt that this should be, if we have a vaccine, it should be prevented. What is the current protection coverage against the serotypes which cause invasive pneumococcal disease in India as reported? So nearly 58.7% are protected by PCV13 and 67% for polysaccharide vaccine. Though we know that polysaccharide vaccine is not as effective, or as the pneumococcal conjugate vaccine is definitely better for prevention. So the serotypes covered, we have now the PCV14, which also covers additional one serotype. But in global market, you have PCV15, PCV20, and there are more in pipeline, which have which are being under in research. The polysaccharide vaccine has broader coverage, but it has some disadvantages as compared to the conjugate vaccine. And what are the advantages of conjugate vaccine are It's immunogenic in infants. It also provides mucosal immunity and reduces colonizations. So it provides herd immunity and thereby indirect protective effect to the unvaccinated population. And this is a very big advantage for the conjugate vaccine. It also has a better response and it primes immunologically for enhanced response for a later infection. And it also has a longer duration of protection. So PCV has a much longer protection as compared to polysaccharide vaccine. These advantages of conjugate vaccine are slowly easing out. Most high-income countries now go in for the broad-valent conjugate vaccine rather than polysaccharide vaccine, which does not offer any incremental advantage over the use of the higher valent conjugate vaccines. So, sorry. And what is the estimated effectiveness of this conjugate vaccine in elderly? Now, this study was in a health management organization in USA, and this was done in an era when conjugate vaccine and PCV13 has already been started and universally in USA. So it was around 2015 to 2018. And besides having the effects of the infant vaccination, the conjugate vaccine provided additional protection to the elderly. So the main salient finding was that 10% reduced 10% of further hospitalizations in patients who were adults more than 65 years old, those who were PCV vaccinated. So they had less hospitalization due to pneumonia and lower respiratory tract infection. So there is an additional advantage of giving conjugate vaccine to the elderly. This study was adjusted for the polysaccharide vaccine in immunization rates also. So what it means is that you do have indirect effects of herd immunity to the adults after starting the conjugate vaccine in infants. But over and above this, for elderly, there is an incremental benefit of giving pneumococcal conjugate vaccine in this populations. So this was the basic this thing. And again, this was a landmark study which was published in New England Journal of Medicine, the CAPITA study, where they studied that as compared to the placebo, the community-acquired pneumonia as well as non-bacterial, the community-acquired pneumonia and the invasive pneumococcal disease all were the vaccine had a good effect for a long time, almost up till 4 years of vaccination. The conjugate vaccine prevented significantly vaccine type of community-acquired pneumonia and non-bacteremic community-acquired pneumonia, as well as vaccine type IPD. So it showed that all these vaccines have good effect. So this is the observational studies. This is a graphic abstract for one of the reviews that you have all-cause pneumonia, PCV13 was only 9 to 12%, but for vaccine type of pneumococcal pneumonia and vaccine severe pneumococcal disease, the efficacy is 40 to 79% for PCV, and which is not so good for PPV23. Because we knew that the polysaccharide vaccine prevents invasive disease, is quite immunogenic, and it prevented invasive disease. But for pneumonia, this didn't have that good effect. So this showed that the PCV has some protection for the all-cause pneumonia as well as, and it is better than giving polysaccharide vaccine. That was the main finding of this study. So people are moving on from polysaccharide vaccine now to conjugate vaccine. So overall, the effectiveness of pneumococcal vaccine for vaccine type of invasive pneumococcal disease is good. And vaccine type pneumococcal pneumonia is also good. But all-cause pneumonia, as you see, that is a different matter. It was just about 10%. So this is about the effectiveness. And just by giving introduction of PCV13 in pediatric population, also, there was a significant change in antibiotic resistant cases in USA. This was the impact of pneumococcal vaccine. And this showed a significant drop in antibiotic resistant cases between 2009 to 2013. Almost 63% for macrolides, 81% for cephalosporins, 83% for penicillins. So this even infant immunization is a very big, has a significant advantage for this reducing antibiotic resistance. Same happened, and this was the results from invasive pneumococcal disease in South Africa, pre and post PCV introduction. So this is trends in invasive pneumococcal disease in South Africa before and after PCV introduction. And you can see there's a remarkable decline starting from the day when they started the vaccination. And showed that the penicillin resistant and ceftriaxone resistant for all ages, as well as the multi-drug resistant, reduced significantly after this PCV introduction. What is the scenario in India? So we remember that we started in 2017 in a phased manner. It was started in 5 states. PCV was given to infants in 2+1 schedule, starting from 6 weeks, then 14 weeks second dose, and 9 months the 1-dose booster. And we started with PCV 13 because we didn't have PCV, the locally manufactured pneumococcal vaccine. After that, we were also got pneumocell, and now mostly it is given as PCV 10. With universal immunization, we are expected to provide immunity. And 2021 November or October, this was completed all over the country. But remember, we didn't do catch-up vaccination. We just gave it to the infants. So with universal immunization, we expect to provide immunity and reduction in disease by the PCV10 serotypes in the adult population. However, we did not make any guidelines for the high-risk group, for example, for adults as well as for children. Although we are giving it to the most, it is recommended to be given to all these high-risk group, but there was no recommendation as such, but it was the main focus was to give it to all the infants which were born in our country. But we did not give it to the catch-up for the children who were born before the introduction of PCV due to programmatic reasons. So, however, we know that currently all professional bodies recommend conjugate vaccine and polysaccharide vaccine for this population. In India, most recommendations say that you should give PCV 13 as well as PCV 20 polysaccharide vaccine following 2 months if you have to for the high risk population. However, we need to say that we need to have data for the serotype replacement as well as whether we really, how much is the indirect protection. So do we need both vaccines or do we need only one of them? This needs to be revised depending on our surveillance data, because and that also will depend on how many years have passed in that area after the introduction. So many areas it was introduced only in 2021. So maybe in 2025, maybe we should have another review of these all the data and to see whether the recommendations might require to be revised. What could be the impact on antimicrobial resistance for giving it on the adults and children? We have already seen in the countries that because of the infant vaccination, the AMR was reduced. But for further, whether the antibiotic prescriptions and all, we need to see there have to be 2 things. The vaccine should be effective and also there should be sufficient coverage. Currently, we have universal coverage for children in India, but the uptake in adult population is currently very low, and even then the high risk is very low. So we'll discuss about the coverage a little later. But in countries, high-income countries, where they have done this for a long time, the impact of influenza and pneumococcal vaccination, this is an updated systematic review, which shows that the number of antimicrobial prescriptions or days of antibiotic use after pneumococcal vaccine was lower in children, and there were 2 studies in adults which were contradictory. One was showing benefit, one was not showing any benefit. However, the overall there was overall benefit was there of giving pneumococcal vaccination, which reduced antimicrobial prescription days of courses as well as days of antibiotics. So there is some benefit of on impact on antibiotic use after giving pneumococcal vaccination, even in adults. But as you can see this from this diagram, the confidence intervals are very wide, and it was crossing 1. So, but infant vaccination definitely was useful. So this is a modeling study by a group which shows that even routine vaccination against strep pneumonia and Haemophilus influenza type B, they have done a modeling analysis, and the salient point is that if you increase the coverage, there will be a more reduction in the antibiotic use. Even if you, if they feel that the group felt that on 61%, there was some 61% reduction in attributable antibiotic use compared to baseline of 0 coverage. But if you increase the coverage to maybe higher, even 11%, then there will be even better, more reduction of antibiotics, and the inequities in antibiotic demand also would be reduced. So there is a merit in increasing coverage of the existing vaccines. So let us go over to the next vaccine, and which is influenza vaccine. Again, this is a significant problem in adults, just highlighting that the adults over 65 years, any hospitalized LRI episode as well as hospitalization is much higher in adults over 65. So no denying that this is a population which requires prevention of influenza. And this is a report from what is the burden of influenza-associated respiratory and circulatory deaths. Again, as you can see, this is more than 65 years is very high. So definitely, this is a population which requires protection. What is the immunogenicity? Seroconversion rates were observed to be lower for influenza vaccination as compared to younger adults. As we know that as the elderly people, there is a waning of immunity, and also there is immune response is little lower as compared to the younger adults. So the seroconversion rates were lower, but still it was having protection. But there are there can be methods of improving this seroconversion and immunogenicity, and these are being tried these days. For example, many countries, high-income countries, are not using influenza vaccines with higher doses as compared to the standard dose. So there can be methods of improving this immunogenicity. The challenge in influenza vaccine is not only that, it is also that there is variability in effectiveness of influenza vaccine by season. So there is a seasonal variation of the transmission of influenza as well as the strain. And if there is a mismatch between the vaccine strain and the strain which is circulating, the effectiveness is very much variable. Also, there are different vaccine products. There is a recombinant vaccine, there are egg-based vaccine, and there are cell culture vaccines. And the egg-based vaccines are little less effective as compared to the recombinant or cell culture vaccines. So this is a very, the effectiveness can be very variable with the product also. And I said you can have standard dose vaccine versus high dose. In elderly and high-income countries, nowadays they use higher doses to get better protection. I'm not sure whether this higher dose is available in India. And also where people are using adjuvanted vaccines to improve the immunogenicity of influenza vaccine for the older population or for immunocompromised who might not be able to mount the desired response. And as I said earlier, by age, elderly versus young adults, the immunogenicity and efficacy is different. So there are lots of challenges as well as influenza vaccine is concerned. Sorry. It also varies from year to year depending on how well the vaccine, we have already said that. The other important thing is it has to be given in a timely manner. And as you know, that the season and the influenza season in our country itself has a different timeline in different states. For example, it starts before the rainy season, and so many places in India they should actually receive vaccine by in April or May, and but the places in northern parts like Kashmir, they are more of like temperate regions, and they need to be vaccinated more close to the winter season. So there's a challenge that if you don't give the vaccine at the right time, the efficacy would be gone. So if you're having a influenza season in July and the vaccine is given in maybe July itself, it may not work that well. The other thing is the protection of this vaccine doesn't last for more than 6 months. So if you are having a season later on and you are giving it 6 months earlier again, it doesn't work. As currently, as you know, that we are using a Southern Hemisphere vaccine. I didn't see many studies on India, the efficacy of vaccine, effectiveness of vaccine in adults, although there are studies in children, there are studies in children with the variable results. So, but the efficacy was in the RCTs, it was efficacious in children. Typically, the efficacy of effectiveness of influenza vaccine, even in high-income countries, ranges from 40 to 60%. It reduces, but the important thing is it reduces the severity of disease and risk of hospitalization, especially in those with chronic lung diseases and diabetes. This is extremely important, and even chronic kidney disease, all kind of vulnerable population, the influenza vaccine should be given. The vaccinated adults were reported to have also lower risk of ICU admission as well as lower risk of flu-related deaths. So there are, if it is effective, the vaccine is matched well, it really works well. But if it doesn't match well, then it does not work so well. And this was what was seen in this Cochrane database of systematic reviews. And what I would like you to see is that the variability with vaccine matching. If you have a good more transmission in epidemic year and the vaccine is matched, it works very well. But if it is a non-epidemic year and there is vaccine is not matching, then the vaccine may not work that well. So this is important, but overall still the effect was positive only. So regardless of whether it was matched or not matched, overall effect was there. And this was for hospitalization in community dwellers. This effect might be better in long-term care facilities and in nursing homes. Definitely the effect was more. So if the transmission is higher, the vaccine is well matched, then it works very well. So and I saw one study on efficacy of influenza vaccine and COPD, which was conducted in Delhi, where they saw that overall effectiveness of influenza vaccine was about 67% because they saw the outpatient visits and hospitalizations, acute exacerbations of COPD before and after influenza vaccination. So definitely there is a merit in giving this vaccine to especially diabetics, COPD, chronic kidney diseases. They should all get the appropriate vaccine. This was another one which shows that if the vaccine is not well matched, just to put it in proper perspective, then if poor vaccine effectiveness against influenza B related acute respiratory infection, because there was matching was not good. So we need to have a good, well-matched vaccine and a timely vaccination for the effective control and prevention of influenza. Looking at this, the because of influenza is recommended in high-risk group by WHO, the SAGE Strategic Advisory Committee of Experts on Immunization, they did a cost-effective look at a cost-effectiveness of the studies which have evaluated in low and middle income countries. I don't think there was any study from India, but overall what was seen was that it is not cost-effective to immunize children in low middle income countries, but older adults, it is cost effective. Same for healthcare workers, it was cost saving, and also pregnant women. So it's recommended that low middle income countries should start vaccination, but it should be specifically for pregnant women and older adults, elderly population, as well as an at-risk population and healthcare workers probably. So I think we need to have a similar study in our own country by modeling or whatever the standard ways of doing cost-effective analysis and we should be advocating for the good effective pneumonia vaccine for elderly population because it is really vulnerable to influenza. And what was the impact of influenza vaccine on people receiving antibiotics? Again, the impact was, overall effect was favorable. But if you look at the subpopulation of adults, it wasn't that working that well in that population. But in the younger population, overall proportion of people receiving antibiotics was lower in those who were vaccinated. Same for, it was for the, this was again antibiotic usage, systematic review. Again, it was overall effect. This was another outcome. It was, and the subgroups were chronic bronchitis. You can see it was, the impact of vaccination was much higher. And overall, again, the overall effect was there. So on reduction of antibiotic usage. So there is potential impact of reduction of antibiotic usage after influenza vaccine. And this is an updated analysis which was looking at the different areas of the WHO regions. Again, the overall effect was positive, that it was number of antimicrobial prescriptions or day of antibiotic use after influenza vaccination were lower in people who were vaccinated. So there is a potential modest effect of reduction in antibiotic usage after influenza vaccination. Another inverse relationship between influenza vaccination and antimicrobial resistance. This was not only on the antibiotics, it was on the AMR in E. coli and Klebsiella isolates. And they found negative correlation between influenza vaccination and AMR. So they think that there is an inverse relationship. So if there is higher coverage, the AMR would be reduced. So again, this shows the effect of this. Then there are dual vaccination. If it is there, how does it affect? So this was a study, but this was not on pneumococcal conjugate vaccine. This is on polysaccharide vaccine actually. And this shows again that it favors the dual vaccinations as compared to influenza vaccination alone. So let me go to the most other important thing, that is what is the uptake of adult vaccination. Globally, this is the scenario that influenza vaccination rates are very high in high-income countries. But if you look at China, Jordan, Poland, there's none from India. There is no this thing. So there is this. The blue bar is for the aged people more than 60 years, and green bar is for 50 to 60 years, 15 to 60 years, and the other one is for children. So all countries do not recommend it for all populations, but you look at the blue bars, we would concentrate on that. You see that Belgium, UK, Brazil, Brazil is maybe the low middle income country which has high. Otherwise, it's all, there are hardly any low middle income countries which have good vaccination. Even in these countries, the overall coverage, say in Portugal, is just less than 50%. Denmark also 50%. So they are not as good as one would expect them to be. So there is uptake of influenza vaccine could be higher in even the high-income countries. In India, this was one study which I found. There were two studies actually, one from Jodhpur, which were a little higher than this, but coverage of vaccine in India in this, and you'll be surprised that influenza vaccine was only 1.59% of the people studied, and pneumococcal vaccine was even lower, 0.74%. So this is actually, this is what was very big concern, that even in the people with, and these did not have only low income, there were some who were had better income also, but there was disparity in the coverage. The poor people had lesser coverage, but even in the rich, the coverage was very low. And if you talk to our doctors, whether they take influenza vaccine, most elderly people in a vaccine, and I'm surprised to see that most people are not taking the vaccine, even when they have the insurance, when they have the money to buy the vaccine and get the best vaccine, the coverage is very, very dismal. Why it is so low? Maybe it is not lack of awareness. Maybe healthcare workers are not advising. They themselves are not taking. Perhaps there's vaccine hesitancy. And of course, data gaps. There's a lot of paucity of local data to make informed decision for many committees and many physicians. Of course, comorbidities require that the people should take more vaccine, but in fact, people are not taking vaccine because of that. And inadequate access. And we were talking about it just before the seminar. This is a lot of out-of-pocket expenditure. And even if you have money, there are not lack of adult vaccination clinics. I mean, nobody tells them to go to this place and get it. And if at all, I mean, the pediatric vaccinations are held in the morning at one time, or not every day though, in big hospitals, but may not be the time when the adults are available. So I don't know. This inadequate access is something that one can think about, that how we can reduce it. Then, of course, there's lack of coordination between levels of healthcare, and this is not integration of preventive services with the facility-based care. And perhaps I think we need to have a national policy on adult vaccination. We have a national vaccine policy, but I don't think we have anything regarding adults on that. However, we have some strengths and opportunities. We have a strong, well-established universal immunization program, which is doing quite well, very well. And we have learnings from COVID-19 vaccination, where we could really vaccinate all our population in a short duration, which was very commendable, I must say. We have a robust cold chain system, which has a e-win system, and it is digitized and it is well controlled. We have now trying to having universal health coverage, also Ayushman Bharat scheme. So these are the places through which we can think of giving vaccination. And we also have support of digitization, as we know that Abha ID is being considered, is already in the pipeline. So these all things can make the vaccination a reality for the public rollout easier for us. But for considerations for rolling out vaccine in public health programs are not only technical. We know that there is a disease burden. Disease burden is there. We have morbidity due to these vaccine preventable diseases. We have high mortality due to these. Cost effectiveness also, we can do it. And there it is shown to be, especially influenza, as I said, it has been shown to be cost effective. Safety, these vaccines are quite safe. They have been in pipeline in market for several years. Although we need to keep on looking at the safety, but by and large, they are safe vaccine. It's the programmatic considerations which I think are a big issue. Vaccine supply. The logistic issues, cold chain, personal infrastructure. For influenza vaccine, you get in February, the Southern Hemisphere vaccination composition is decided in WHO. And the companies, if we have to get the right vaccine, we have to have it by April. So most companies are doing it, but if you have to do it in a large scale, I'm not sure how good that would be, because you'll have to have several manufacturers making that vaccine. quickly over short period to keep up with the changing strains. Well, of course, affordability, financing, and procurement. So these are the logistic issues are very important when you are talking about public rollout. And of course, social issue is perception of risk. Many people do not feel there's that much of a risk. COVID was a aberration, I would say, because it was really people didn't know anything about it, and and there were deaths due to it, and suddenly there was a lot of acceptance at that time in 2021 when we rolled out COVID. But currently, I'm not sure what is the perception of risk by the public, and this requires a lot of advocacy by the professional bodies to make public aware, to increase the public awareness. So there are considerations for rolling out vaccination, but there is a merit and there is a technically we need to have this vaccination in this population. So what are the key messages? The high risk population and older adults should receive vaccines. And I think this is their right. It's a human right issue. They need it for their own protection. So regardless of whether they reduce antibiotic coverage or like impact on AMR, I think they do need the vaccine, and there is a merit in giving it through public system. Of course, that has to be thought, the logistic issues have to be sorted out. Continued surveillance is required for respiratory pathogens. I think this is extremely important. We need to put in more efforts in the continued surveillance of strep pneumonia strains and as well as influenza virus, which we are already doing, though. It's not that it's not being done, but even more, needs to be continued in the same way. The currently available vaccines and influenza vaccine and pneumococcal vaccines do have the potential to reduce AMR. But the main thing is we need to improve coverage of adult vaccination, even without the public rollout. I think there are many things. If we may increase the demand, even through the professional bodies, when the people are admitted with any disease and they're getting discharged, they should be advised to get vaccination. And if we have more adult vaccination clinics or more advocacy for this, we need to really improve the coverage. And of course, there is a need for better vaccines. We need to have universal vaccine against maybe influenza and a broader coverage of pneumococcal vaccine. Thank you very much. I have not talked about many other diseases because they're very specific. So I've just taken the two. Considering the time, I thought I should go in detail about these two vaccines. Thank you very much, and thanks for patient listening.
Thank you, ma'am. That was a wonderful talk and very, very enriching and very enlightening. And you have been able to bring out the nuances related to the vaccines and how vaccines can prevent so many of these, not just the viral, but also the bacterial infections. So yes, definitely. Now that the ICMR has taken over a lot of VRDLs under them, and now many of them are being upgraded to the IRDLs. So they're going to look after at bacterial health, bacterial infections also. So it's not just the viral infections, but the bacterial infections as well, which would be under the purview of the infectious disease research, these labs. So thank you so much for your wonderful talk, and it was very, very enriching and enlightening for all of us. I would like to, if any questions are there, I'd like the organizers to please go through that.
I think, thank you, Sumit. We'll just hand over to Dr. Anurag Bhargava now to moderate the question and answer discussion. Just a short introduction about Dr. Anurag Bhargava. He's a professor of internal medicine. He's at present the head of the Center for Nutrition Studies at Yenapoya College, deemed to be University in Mangalore, Karnataka. He specialized in internal medicine from AIMS New Delhi and subsequently has done a master's in epidemiology at McGill University in Canada. And of course, he was involved in the founding of Jan Swasthya Sahyog, which is a people's health support group which runs a rural community program. Dr. Anurag Bhargava, we'll hand over to you to moderate the question and answer discussion.
Thank you, Dr. Aneja, for that illuminating talk. And I think your restriction to few of the key vaccines was also appropriate, although we should cover the other groups at a later stage. I just wanted to flag one group here amongst adults, and which has been mentioned in the guidelines, but we can just take it separately, and that those are the healthcare workers. So we find that even in the people who are at risk of many of these diseases because they are involved in healthcare work, their coverage is also not optimal. And every year we see, chickenpox outbreaks in nurses, and so it's one thing. And maybe if we start with healthcare workers and optimizing things, then we'll have, we'll be setting the stage for other things. So there have been a number of questions in the chat. One was specifically, in fact, many of them are on pediatric immunization. So you're the best person to answer this. So one question is about PCV coverage, programmatic challenges for children in hard to reach areas. And is there any geographical variation on PCV coverage in children? So, and could you suggest any policy recommendations for overcoming logistic and programmatic challenges? So this was about PCV. There is another related question that there is still a highest number of zero-dose children globally are in India. How do you, how should we reduce this burden? And so I think we can start with these two questions. I'll come to the others. Yes.
So actually, this was not the topic of my talk,
Yeah,
so I didn't look into
yeah.
that. But I think the government is already doing this in the Mission Indradhanush, and zero dose has also been taken up by the immunization division. I think Dr. Pavan Kumar was, if he was there, he could tell you more about it. So these things are well known, and they are looking at it. But there are programmatic challenges, definitely. But I think in the last few years, the coverage has definitely increased, although COVID put a little bit of gap in between. We had a, in 21 and 2021, there was a little bit of reduction in coverage due to the lockdowns and the system problems are due to COVID. But again, after that, the coverage has increased definitely. Zero dose also has been taken up by government. I'm not sure about the current scenario, and they are looking into this. The Mission Indradhanush was primarily for these Mission Indradhanush 1, then we had Mission Indradhanush 2, and again the zero dose was also been taken up by the immunization division. But I'm not sure about the current scenarios.
There is also one question about anybody with a history of egg allergy and being given an influenza vaccination. So is this contraindicated with known egg allergy? Yeah.
No, it was not. It is not contraindicated any longer. The egg allergy is not a major issue with influenza, but there are other vaccines also which are not egg-based. So we have recombinant vaccines, cell culture vaccines, subunit vaccines. So but this is actually not an issue with even egg-based. It doesn't cause any. No, there is no contradiction indication.
One thing which was coming out from some of the adult guidelines was, again, it's not an unqualified contraindication, but if somebody has just had urticaria, then it can be administered with caution in with egg base. But
if the person
with
is
more than
often the people who are allergic to some vaccination, we don't know whether which part of it is vaccination. There could be so many components of a vaccine which could be allergenic, have a potential to cause allergy. But it's better if a person is known to be allergic to something to give them under. When you are administering vaccine, you have to be more careful and watch them for at least for half an hour or 1 hour and give it under supervision. That is what we recommend. Yeah.
There's a question on when is single dose pneumococcal vaccine expected in India?
Single dose means? Oh, you mean the
PCV 20? I think that's what they're
20.
talking.
Okay, I don't know.
The Pfizer. I think it's 2 years from now, actually.
Yeah, but right now it is not there. Yeah. And it has to be, remember, it's not only just some doses available. It has to be in that number to make it, viable option for a public rollout. But I'm sure people in our country, there is a capacity to make the same vaccine. So after this there is a patent transfer, then India can also manufacture vaccines, and there is a lot of research R&D should be done in that to have locally manufactured vaccines. And I'm sure there are efforts for that.
finally somebody has, conceptually said that because you called it a human right issue, do you think there is a lack of rights-based framing of this problem? And where does
I think it is. I think everybody has a right to equal access, and there is definitely. But public rollout is, it's a different ball game altogether, because public rollout, once we say that we have to give it, you have to get it in all the arms. It's not enough to just make recommendation. Professional bodies, we can make recommendation, but when government says it has to give it to everybody, it has to make sure it goes to everybody. So we need to have good preparation for that, and good, you have to have good plan for that. Just by doing it, saying it, and not doing it will not make a difference. So we have to have a good, operationalization is a issue. It's not only the cost of vaccine, and we have infrastructure, we have lots of things, but I'm not sure about how much is the manufacturing capacity, how much is the procurement, and how much is the cost effectiveness. These all have to be really looked into properly.
Dr. Priscilla, with your permission, can I just flag one more issue here, because Dr. Aneja is here, and just add an issue that I feel. So one thing is that when we are talking of adult vaccination, we are seeing a reemergence of many diseases which generally happen in children and now are affecting adults. And it will be easier to argue for, say, tetanus, diphtheria, booster, and of course, hepatitis B vaccination for everybody who is at risk, because it's already part of the children's program. Similarly, your pneumococcal vaccine could be extended to, at-risk people in adults. So, because we are seeing this situation happen.
Yeah.
Now, there was a measles outbreak in adults in Pune. A lot of people, rabies is a huge issue. And simply it can be prevented by 2 doses, even of an intradermal. So I'm just saying that if we, when we are making a policy brief, actually we should not forget maybe these aspects of adult immunization, which should be put in. And of course, the influenza vaccine is something. And again, the data that you showed from Kashmir was a little concerning, because there's a mismatch between the strains that they found and what the vaccines were covering. So when you said that there is data available across the country, do we really have very good data to make this match possible? Maybe just anybody, Dr. Dipali, would like to answer this. But a request for just looking at adult immunization, healthcare workers also, and some of the, just the measles, the tetanus, rabies, which can be actually easily implemented. And once it is there in the national program, I think there will be an uptake and with awareness.
So let me say that rabies, for example, we do get it from the public sector. There are specific centers for rabies. If person has rabies, for the free vaccination. Again,
this
for
is the pre-exposure, just 2 doses.
not pre-exposure, but post-exposure, yeah, which is of course pre-exposure. That needs to be looked into. The DPT, I think DT is a very important thing that you have mentioned, and because tetanus can be very severe at older age also, and many people are thinking that childhood vaccination is enough, but DT needs to be given even to adults if they have not been vaccinated for a long time. So
even boosters need to be given every 10 years.
Yeah, booster, definitely. I have seen diphtheria in our my own postgraduate students sometimes. So there is definitely, you need to, especially for people who are in healthcare workers, and this is an important thing. Pediatricians, I have seen so many pediatricians getting affected by diphtheria because the immunity has waned. So there has to be, we have not touched about them, because I think that is definitely, it's a, till 10 years, of course, the government is also given but after the childhood, the adult physicians have to see whether how many doses they have received, and the policy has to be the vaccination policy, and like CDC has made it for the adults at risk, for the healthy adults. You have to have the complete guidelines separately for each group, definitely. And I think what you have flagged is very right. We need to have an adult policy document which says that who all should get what vaccines. Yeah, sure.
There is already WHO guidance available on this.
Yeah.
So just basically incorporating those aspects in the policy brief and of course, any other things that we feel. I'll hand it over to you, Dr. Priscilla, and for the.
Thank you, Dr. Anurag and Dr. Satinder Aneja, for this wonderful discourse. I think we are all quite passionate about adult vaccination becoming a reality, just as the success of childhood vaccinations were. I'll just now hand over to Dr. Umang Agarwal. Dr. Umang Agarwal is a senior consultant in PT Hinduja Hospital in Mumbai, and I will hand over to him to make the concluding remarks.
Thank you. Thank you so much, ma'am. And at the outset, I would first like to thank Dr. Priscilla, ma'am, to organize such an amazing consortium of experts from all across India to actually propagate the importance of vaccination across all age groups and the importance of that particular aspect in preventing AMR. I think one of the points raised by you, Dr. Bhargav sir, was about adult vaccination and how we are propagating it. I think there are certain guidelines that have come up from adult vaccination as well. So I think we are moving at the right side. And now, just to tell you that ECMID is coming out with guidelines on vaccination in immunocompromised host post solid organ transplant. So they will be released during this year in ECMID. So I think on 12th or 13th of 12th or 13th of April. So we are making strides towards that aspect. And I think it was a phenomenal lecture by Dr. Aneja ma'am, and very beautifully explained about the influenza as well as the pneumococcal vaccines. Undoubtedly, vaccines help in preventing AMR and reduce antibiotic use. So whenever a patient comes to me, at least in the OPD, and when they talk to me about this particular aspect, I tell them that if you have taken your vaccine and if you have taken the vaccine, you're by and large protected against the disease. And if you're protected against the disease, then why will anyone prescribe you any antibiotics, you know? So that is how we try to propagate this particular message across. So yes, I think thank you all for joining this particular webinar. Thank you, Dr. Rupali, Dr. Bhargav, Dr. Aneja, and Dr. Sumitra for your excellent views. And as Dr. Bhargav said, that we do want to talk about vaccines in other populations as well as the different kinds of vaccines that we have. So hopefully the next webinars will be on that then. Thank you so much.
Thank you and bye.
Bye, ma'am. So thank you everyone for attending, and we'll see you soon next month with another webinar. So thank you everyone. Good night and good morning, whichever part of the world you're from. Bye-bye.
Thank you, madam, for your talk.
Thank you. Bye.
Thank you
Bye.
so much, ma'am.
Nice talking to you. Bye.